The Veteran Lived Experience series features personal conversations with veterans who have agreed to share their story on topics prevalent in the veteran community. Veterans are joined in discussion by professional experts and members of the Veterans Health and Wellness Foundation team.
While the month of November is highlighted for many different reasons, it is especially suited for our topic today, veterans and lung cancer, improving outcomes and survival rates through early screening. National Veterans and Military Family Month, National Lung Cancer Awareness Month, National Native American Heritage Month, all sit at the intersection of lung cancer being the leading cause of cancer mortality among American Indians and Alaska Natives, and the #1 killer of veterans. And in addition, veterans are at twice the risk of non-veterans for developing lung cancer. Today, we were slated to have two guests, Dr. Nicole Tanner, who's a pulmonologist in Charleston, South Carolina, and is affiliated with the Ralph H. Johnson Veterans Affairs Medical Center, and Mr. Douglas Cross. Unfortunately, he is unable to join us in person today, but we're going to introduce him to you through a film or video that he made that was called the NASA Moonshot Lung Cancer Awareness Month. And so we're going to play this for you, and then Dr. Tanner and I will begin some additional conversation around this issue of lung cancer, and particularly around the morbidity and mortality that it causes for our veterans.
Well, Douglas, I grew up on a tobacco farm in North Carolina back in the 50s and 60s. I lost my father to colon cancer at a very early age. He was only 52. I was in the 8th grade at the time. Wanted to do something different, though I joined the Army. And then in 1978, NASA selected some new astronauts for the shuttle program. I had the opportunity to fly in space several times until I retired.
I never thought I'd be sitting side by side with an astronaut. I was born and raised here in Houston, Texas. Upon graduation, I went straight into the Air Force. Since that time, though, I've obtained a bachelor's and master's degree in psychology, and now I'm presently a substance abuse counselor, helping people overcome their addiction issues with substances. Well, last year, I just started considering, I wonder, do I got cancer? First part of January, they took a scan. I actually have cancer. We was able to get this done and resolved, so cancer is not gonna be what knocks me out of nothing. But it was just an appreciation of life. I couldn't do nothing but get emotionally happy.
You're just a true inspirational. You're brave, you're a courageous, strong man. I think you're an example that we all should emulate, myself included. I'm going to take your story to heart.
I'm one of the proudest veterans in this VA right now because I'm standing. Look at me, I'm strong. That I don't want to leave my wife with nothing undone. I don't want to leave my kids, my grandkids. Early screening is the most effective way of dealing with anything that may take the quality of life from you. And that's what this is all about.
I'm much more proactive about getting screened for not only lung cancer, but other diseases. And I want to thank you for sharing that lesson with me.
You've heard a little bit from Mr. Cross there about his journey with lung cancer and how it was discovered. But now I wanted to ask Dr. Tanner if she could expand a little bit on that in regard to his journey and her involvement with that before we discuss a bit more about the lung cancer itself.
Sure. Thank you, Dr. Lewis. It's really nice to be with everyone here today and talk about lung cancer, which doesn't get enough publicity, I think. And so the journey that Mr. Cross just described was that of lung cancer screening or early detection. We've been screening for other cancers, including breast and colon cancers, along with cervical cancers for quite a bit of time. But lung cancer screening is kind of the new one on the block. We've had evidence to support lung cancer screening since 2011, but did not get recommendations from the U.S. Preventative Services Task Force until 2013, and then coverage by Medicare and Medicaid and insurance until 2015. And so Lung cancer screening is relatively new, but I biasly think that it's probably one of the most important screening exams that we have to offer our veteran population. As you highlighted, lung cancer is one of the deadliest cancers in our veteran population and in the United States. And so the journey that was described there was a good one, you know, to look for cancer early at a chance for it to be cured.
Well, thank you for that. Can you also now just give us sort of a bit of a history about lung cancer itself, some of the things that cause it, et cetera? We know probably from hearing about it for such a long time that smoking is likely one of the highest causes or most frequent causes of lung cancer. But what other things would we need to consider in regard to risk for developing lung cancer and causes of lung cancer?
Sure. So to get to the first part of your question, the history of lung cancer is that up until recently, we really didn't have we didn't have a good screening test. And so when you can't screen for something, it means you can't find it early in someone who doesn't have symptoms. The whole purpose of a screening exam is to evaluate a group of people that aren't having symptoms, to try to find something early, at which time it can be cured. And so prior to the advent of lung screening, most people that I would see that would come through my clinic were diagnosed with late stage cancers where the cancer had already spread. And so the chance of cure in a stage 3 or stage 4 lung cancer patient is much lower over 5 years compared to someone who's diagnosed with an early stage cancer that can potentially have surgical resection. And so that was the history of lung cancer, was that at 5 years, only 17 out of 100 people diagnosed would be alive. But if you look at the earlier stages, stage 1 cancers, you know, at 5 years, maybe 80% of those individuals are still alive. And so that was the whole goal, was to identify a test that could find this cancer early. And so as it relates to risk factors, as you pointed out, really combustible or tobacco smoking cigarettes is what we know to be the main risk factor that leads to lung cancer. And in fact, in the 2 large trials done to give us evidence for lung cancer screening, people were made eligible based on smoking history. At the same time, there are other risk factors for lung cancer. We do know that anywhere from 10 to 20 out of 100 people who develop lung cancer never smoked cigarettes. And so how to capture those folks is a bit more difficult because you'd have to screen a whole bunch of people that never smoked to find one cancer. So from a population health standpoint, it's different. But everyone's individual risk is there. And so other risk factors might be a family history of lung cancer or a history of another type of cancer. If you've had one cancer, you're more likely to develop a second cancer. And then there are certain exposures that we link to lung cancer, for example, asbestos exposure. Asbestos exposure coupled with smoking cigarettes actually increases a person's risk exponentially. It's almost twice as high as someone who did not have asbestos exposure and also smoked. There are some links from an epidemiology standpoint to developing lung cancer if you were exposed to radon. How to quantify that is very difficult. Similarly, we know that folks that worked in industries where there was a lot of tobacco smoking, for example, in bars and restaurants before smoking was outlawed. And so we know that that contributes to risk. However, it's really hard to quantify the amount of secondhand smoke that would lead to a cancer. And so as it relates to guidelines for screening, we're very focused on smoking tobacco cigarettes as the risk to indicate for screening.
So with that knowledge and with that information, is there any research being conducted or considered where it looks at those who have had larger amounts of exposure to secondary smoke? I mean, as you mentioned, you know, bars and what have you before smoking inside of buildings, et cetera, was prohibited or banned. There were many folks, bartenders, et cetera, flight attendants, you know, all of those kinds of folks who had enormous exposure to secondary smoke. And has there been any studies around that previously, or are there any planned studies to see whether or not that is something that should be considered?
Sure. So I don't know of any planned studies in the population that had a secondhand smoke exposure. As I said, it's very hard to quantify hours and risk. And so I think like the most important message for what we're doing today is if someone is concerned that they're at risk for developing lung cancer because of other exposures outside of personally smoking cigarettes, then that's a conversation they really ought to have with their provider to talk about the risks and benefits and the number needed to screen to find lung cancer, et cetera. Because while we really want to highlight the benefit of lung cancer screening, it's not without risk. There are false positives that can lead to procedures for something that turns out not to be a cancer. So we have to be very careful. But I do understand that lots of people have concerns because of different exposures. And so I would always point them back to their providers to have a very frank and discussion around it. A lot of times the anxiety can be allayed. And there can be other discussions about what to look for and what to consider in people who don't necessarily meet criteria. As it relates to research and other exposures, yes, there is active registry data that's being collected to try to make these type of epidemiologic links between other exposures, burn pits for example, that are cogent to our veteran population to identify what risk factors might be there that would lead to developing lung cancer in the future. And so those studies are actively ongoing.
Was there anything included within the PACT Act that would have encouraged or informed veterans and or their caregivers, et cetera, about early screening for lung cancer if they were smokers or had certain other exposures that they might have been concerned about?
Sure. So as you know, the PACT Act has really expanded the opportunity to utilize the VA for healthcare services. So there's kind of two separate hats there. We are certainly encouraging all of our veterans, those that come into the VA as part of the PACT Act, or those that have been part of the VA for many years, and just veterans in general who have smoked cigarettes. If you're between the age of 50 and 80, and you have a 20-pack year smoking history, for example, you smoked a pack a day for 20 years, 1 times 20 is 20 pack years, or 2 packs a day for 10 years, 2 times 10 is 20. If you hit that minimum threshold of 20 pack years and you fall within that age range, and you're not currently having any symptoms, then you would be considered for lung cancer screening. And it's certainly something that you should talk to your provider about or actively ask about. And that goes for all of our veterans, whether they come in through the PACT Act or not. Certainly, there are now more detailed exposure questionnaires that are happening with veterans that are entering the VA, burn pit registry questions, for example. And certainly we're trying to elucidate what types of exposures are there, what type of particles were inhaled, and come up with a way to potentially recommend screening in the future. But as it stands now, we're encouraging, it's the low-hanging fruit, those people that smoked cigarettes and did so for a long time, to talk to their providers about lung cancer screening.
Okay. Well, as you know, as we have conversations about these different illnesses, injuries, diseases, et cetera, that impact our veterans, there's often some differences between the impact on female veterans versus male veterans. Have you seen any of that in regard to lung cancer?
Sure. So lung cancer really knows no gender bias. It's the #1 cancer killer in both females and males across the board. It kills more than breast, prostate, and colon cancer combined every year in the United States. And that's no different between our veterans and the general American population. As it relates to gender differences and benefit from screening, there was a large trial that was conducted in the Netherlands called the Nelson trial that gave us evidence for screening. And there is an indication there that women actually stand to benefit more from lung screening. So if you are a female veteran who smokes cigarettes and falls into those categories that I talked about before, I would strongly encourage you to talk to your providers about screening, because you really would potentially stand to benefit more than your male counterpart. So those are the kinds of differences that we see as it relates to screening.
And when veterans come to the VA or consider getting their healthcare at the VA, what's the process for getting screened for lung cancer for a veteran?
It's very simple. It involves providing your tobacco pack year history, which is what we just talked about, age that you started smoking, age that you quit smoking, or if you're currently smoking, the tobacco pack year history. And I should mention that if you have quit smoking, eligibility is if you have quit within the past 15 years. So if you quit 30 years ago, potentially not eligible for screening based on the task force guidelines. And so once that is there, then the next step is to have a conversation about the risks and the benefits of lung screening. There are many benefits and few risks, but we want people to be offered screening and make an informed decision that is in line with their preferences and beliefs. Okay, so there are some people that at the end decide that they don't want to be screened, and that's okay, but at least they've been offered. And so once that conversation is had, the provider places an order for the low-dose CT scan, and it's very simple. It's an open, non-claustrophobic scan. You lay on a table that sends you through a tube, but there's no IVs. The CT technologist will ask you to hold your breath, and the table goes through the tube and it takes pictures of your lungs. The whole scan is done within 2 minutes and then interpreted by the radiologist. So non-invasive, very quick once you make the decision to be screened.
Thank you. Well, the other thing I thought about as you were responding to that question, you mentioned something about, the 20 pack years, and if you had stopped, 15 years versus 20 or 30 years. What if someone has more space in between that 20 pack year history, but has also had other types of exposures? So they have a 20 pack year history, but they stopped smoking. More than 15 years has lapsed during that time, but say now they were engaged in Iraq and Afghanistan and exposed to burn pits and the particulate matter that was in the air from there. Are they at a higher risk, and should they be screened more so than someone who had a 20 pack year history and had no additional significant exposures like that?
Sure. It's, again, very hard to quantify, and we don't have like direct linkage. There was just recently published some data from Southern California looking at particulate matter and association with lung cancer development. Obviously these are not our veterans, but it's the same idea, the size of the particulate matter and developing lung cancer. And the association was there. It was kind of weak, and we don't really have that kind of data. What I would say is that we do have a number of validated risk calculators that take into account things other than age and smoking history and years since quit. These include race and BMI or weight, and a history of COPD, those types of things. And so I would tell someone who's concerned to have a conversation with their provider. And there are, again, validated risk calculators. So all of those factors can be plugged into this calculator, and it spits out a number and will tell you what your risk for developing lung cancer is in the next 5 years relative to other similar folks. And so that's actually very useful. And those tools are available online. One website that I would direct people to is shouldiscreen.com. Where you can put in all of your risk factors, and it will let you know what your risk for developing lung cancer is in the next 5 years. And that's something that clinically we'll utilize for folks that don't necessarily meet the task force criteria. At the VA, we are screening people that meet task force criteria, but we also consider and understand an individual's concerns. And so I would say if you are personally concerned and you don't meet the task force criteria, that we could certainly have a better and more detailed discussion with individual risk based on these calculators.
Well, what have you seen? You mentioned, race, ethnicity during your response there. What have you seen in regard to differences, say among African Americans, Latinos? We don't see very many Native American, Alaska Natives that come through our clinics, but some do get some care through the VA as well as through the Indian Health Service. So what has those percentages perhaps look like in terms of what we've seen in regard to risk as well as diagnosis and early screening?
Sure. So, epidemiologically speaking, and based on studies that have been done in the US population, we know that Black individuals are more likely to develop lung cancer than their white counterparts. They are also more likely to develop lung cancer at an earlier age than their white counterparts. they're also more likely to develop lung cancer at a lighter smoking history, meaning less than a 30-pack year history. And so the reason I bring that up is the initial task force guidelines was for a 30-pack year history. And in an effort to reduce the disparities between those that were eligible to be screened, the version 2 of the task force criteria reduced the amount of tobacco from 30-pack years to 20-pack years in a hopes of capturing more African Americans that might not have been eligible for screening otherwise. And so those are what we see. Also in the general population, Blacks are less likely to get timely treatment. I will say, and this is a very proud thing to say about the VA, is that when you are hooked up into the VA system and receive your care at the VA, that racial discrepancy between treatment and outcomes dissipates because of access. And I think, we do a really good job of treating all of our veterans the same and offering all of the services the same, more so than outside of the VA.
So do you have any specific recommendations that you might give to African American males, females, et cetera, as it relates to early screening for lung cancer in regard to anything else in their medical histories?
Well, I mean, certainly if you have a personal history of cancer, or if you have a family member with a history of lung cancer, that is something that, should really kind of ping you. But I would just say globally, lung cancer screening benefits everyone, regardless of race. But what we do know from studies that our group has done here, looking at the National Lung Screening Trial, which gave us the evidence for lung screening, is that Black veterans stand to benefit more from lung screening than their white counterparts. And so I would say that you should think about it a little bit harder if you're kind of on the fence. If you are, a Black veteran, you certainly stand to benefit from screening in a measurable way as far as life expectancy goes. And so I would encourage everyone to consider, but especially that group.
Well, we sort of kicked this conversation off with a video featuring Mr. Cross. Was he a direct patient of yours, or do you know him just through the VA?
No, he was not a direct patient of mine, but I know many veterans like him. So no, I did not have the pleasure of meeting him.
Okay, well, again, as we watched and heard his conversation in the video, and you have mentioned throughout our conversation that it's important for individuals, if they have some concern or if they feel they should be screened, whether they meet the criteria or not, is to have a conversation with their healthcare provider. Can you provide some sort of insights into what that conversation or what those conversations sort of look like or sound like for those folks who are your patients who have come in? Have any of them struggled with whether or not they should get the screening, or if they did, what was the dialogue that might have changed that, changed their decision to get that screening and perhaps save their lives or at least enhance their health outcome from having lung cancer?
Sure. If it's okay with you, I'd like us to take it one step back as it relates to this, and then I'll kind of elaborate on what our conversations go like. I think, and this is true across the United States and even within VA, what we've seen ever since lung cancer screening has been approved is that the uptake has been low. Right now, estimates are that only 11% of those eligible, and there are 14 million eligible people in the United States have been screened for lung cancer. And so the question is why? Why is that so low? If you look at breast and colon cancer, they enjoy very high uptake in those that are eligible. And it's important to note that this is the first time that we are advertising a screening service, not just because of your age or family history, but of a poor health habit. And so it's really important for us to talk about the stigma related to smoking cigarettes. I have heard veterans in my practice tell me, well, it's my fault. I smoked cigarettes. I did this to myself. And there hasn't been, they feel this a sense of nihilism, like I deserve it. And I think even in the general public, folks say, well, it's their fault. They smoke cigarettes. And you look at October, breast cancer awareness, and everybody is very supportive of that. And we haven't yet appreciated that type of advertisement and excitement around lung screening. And there's a huge stigma. I mean, even in medical practice, we'll call people smokers, and that's labeling. It's really important to say people who smoke. And so I think what's really important in the conversations that we try to have is not to make it anyone's fault. You know, I'm sure you've had these conversations on this platform before, but ration boxes had cigarettes in them, and you got a break if you were taking a cigarette break. And that was for many of our veterans, that's when they first started smoking, was when they were in the service. And so there is no fault here. There is no blame. And I think that's the first message that we try to give our patients as they come in. And oftentimes, if we can reframe that conversation at the primary care provider level, to say, you used to smoke cigarettes. The VA has a great screening program. Would love for you to talk to somebody about your risk and the pros and the cons, and let you make a decision around that. That's how we start. I think it changes folks, because there are some people who are very reluctant, like they don't want to know, they think it's their fault. And so if we can kind of do away with that stigma, I think that's really, really key and crucial here, and that what we're working very diligently to do at the VA. Also within the VA, there's a huge push to improve fair and equitable lung cancer screening across all VA facilities. And so to that end, Congress approved funding for something called the Lung Precision Oncology Program, which gives resources to do lung cancer screening in a high quality manner. And so what that means is, what the conversation is that the provider will identify someone as eligible, and in some instances, refer that patient to the lung screening program. And so these programs are dedicated to having these conversations. And so there are informational shared decision-making sheets, so that the veteran can really understand the risk and benefit, and then a shared decision-making conversation. And so you can imagine, when you go in to see your primary care provider, you're talking about your diabetes and your hypertension, and maybe you've got a sore toe, and all of that has to happen in 15 minutes. And so we've really dedicated the resources by way of nurse navigators to set aside some time and call up our veterans and walk them through the process and answer their questions and elicit their preferences. If you had a lung cancer, would you want treatment? How do you feel about coming back every year? Because it's not just a one and done scan, you must come back every year. We want you to know that there's a chance that you'll have nodules, but that doesn't mean that it turns into a cancer. And so those are the types of conversations that are had, and then the scans are ordered and the results are delivered, and we really try to bring people into the fold. And for people that are currently smoking cigarettes, we have various ways to try to help them and encourage them to start on a tobacco cessation journey. So all of that is really incorporated, and what we are trying to do at all VA facilities is to have this type of high quality screening program.
Well, thank you for that information. It is quite valuable. It's always interesting when we're talking about medical conditions and you hear the word stigma come up, because it really is quite a challenge and barrier to getting care for a lot of health needs by veterans as well as others. You mentioned how few have been screened, and we're specifically talking about those veterans who are coming to the VA. As we talk about that, though, we know that there are large numbers of veterans who don't get their care at the VA, but who would still be in need and should have this early screening that we're talking about. So one way I think we could potentially get more of that to happen is the foundation is more than willing to continue to work with you and partner with you as well as the VA to help get this word out. Because most of the times when we're talking about any of these health issues and health concerns, one of the main problems is people don't know, or they don't have the information. We know that the VA, as well as other sources, have tons of information out there. Particularly the VA, it has a plethora of very good, solid information that would be valuable to veterans, but they don't know it's there. They don't know how to access it or what have you. And so one of the roles that the foundation has, or one of our pillars, is education. And so we would definitely look forward to having additional conversations with you, looking at how a partnership can help us get that word out more to veterans, those who go to the VA, as well as those who get their health in the civilian sector, just so that they know that this is available and that it's something that should be done that could potentially save their life or at least enhance their life after a diagnosis of lung cancer. So with that, do you have any other tips or information that you want to get out to those who are listening now, as well as those who will be listening later?
No, I would just add and maybe repeat myself and say, you know, we are in the business of making lung cancer survivors. That is what we want, is to make lung cancer survivors. We are very passionate about getting this word out. And so even if you don't qualify, or you're someone that never smoked, if you have a father, an uncle, maybe bring it up and encourage them to talk to their provider about it or inquire about lung screening. Patients can self-refer. And, you know, really, I think just to kind of piggyback onto what you said, Dr. Lewis, it would be amazing to really spread the word. And I think it's this kind of grassroots type of get the word out, having community coaches and, you know, spokespersons that really help with the uptake of something like this, because knowledge is key. And I think that's really what's been lacking, are these types of campaigns. So I would be delighted to work with you and the foundation and anybody else who's interested to get the word out and as I said, make more lung cancer survivors.
Absolutely. We'll be definitely looking to help you increase those numbers of lung cancer survivors. And as we here at the foundation say, knowledge is power, but not until you operationalize it. And so we're going to take that information that we can get from you and from the VA, get that out into our communities, and then help them act on that and get that early screening and spread that word. So again, Dr. Tanner, thank you very much for your time today, for the information that you've shared with us and for those who will be viewing this later. And we look forward to that partnership as we move forward in getting this word out to more and more of our veterans and their family members so that we can increase those lung cancer survivors, as we say. So thank you all again. And if anyone who is viewing this now or later has any additional questions or need additional information, please feel free to contact us at the foundation and we will get those resources to you. We'll get you any other additional information that you may need also. And again, thank you for joining us today. We look forward to working with you in the future. Take care.